If you thought dental hygienists were only qualified to clean teeth, well, you've missed the plot. Today, we're breaking down the walls that prevent you from seeing hygienists as anything other than functional health providers. That's right. There is nothing else you should be looking at an RDH as. In fact, I was asked very recently why hygienists are even doing myo, and I'm going to tell you why that made me big mad. I'm your Myo best friend. Welcome, welcome, friends. It's so good to have you here with me again. I go live regularly to try to provide education, value, and I don't believe in us doing anything below a standard of absolute excellence. So, if you are ready to up level, you need to join the club, okay? It is a virtual club. It's here. You got to subscribe, like, I got to say all the things, comment. That's how we keep this going. There's nearly 100 hours of content here. 100 hours of content. Where else can you find that for absolute free on LinkedIn, on YouTube? You can't. You can't. So please subscribe, like, share, comment. It keeps it going and it just keeps us all at an accountable level of standards. Okay. Awesome. Right. Myofunctional therapy is changing. It's absolutely changing. It's always changing. It's ever changing. And I think as it changes, people start to believe or forget that it is not what it used to be, but that what it used to be is dentistry. It's that myofunctional therapy originated from dentistry. So why people get so confused when they're like, well, aren't dental providers just really just for like screening these things? And then it's really for therapists of a feeding variety or a speech variety or a physical variety. Those types of therapists actually perform myofunctional therapy? No, we can grow, we can invite others in, we can change and evolve as a field. And I'm telling you, this is not even with inviting other people in. Myofunctional therapy is not in any way, shape, or form like physical therapy. I don't know how many different ways I can describe that. It was actually a physiotherapist or physical therapist in another country who specifically told me that dental hygienists should not be doing myofunctional therapy, or they just don't understand why. And I'm like, I've worked with lots of physical therapists who probably could do what I do. I'm not special, right? But they don't get the concept of what we do and how it occurs. I teach it, so I could probably teach everybody, right? And that's technically what I do when I have them as clients. But there's a reason why physical therapists refer my way. There's a reason why I've worked with so many of them and helped them through their own TMJ things when they've tried working with peers and they couldn't get it done. Because what they're learning is not what we learn in myofunctional therapy. Their understanding of the musculature, for whatever reason, is a little different from our own. And I think some of it is because there's a lot of reaching, right? So physical therapy as a standard of practice is phenomenal. I mean, they go above and beyond and they help and do things I can't conceptualize. But when it comes to this fine region here of motor function and muscle function and dysfunction compensation patterns, like this is where I shine, right? And understanding how to work in that area, it's not the same as what y'all do in physical therapy. You don't need an IOPI where everybody's trying to find a tool or something to validate. It's okay to be subjective. It is totally okay to rely on like what's happening with the patient. Are they feeling better? Are they performing better? Are they functioning better? I don't have a scale for that. And that's okay. It is all right. They're not the same. And they don't have to be the same. You don't have to be a physical therapist to do myofunctional therapy. And you, as a myofunctional therapist, should stop telling people that it's like physical therapy, because you're part of the problem. You're going to be part of the reason why people are like, this isn't even something you should be doing. It should really just be for physical therapists, because you're trying to do physical therapy. You're practicing outside of whatever scope you're in, and whether you're an SLP and OT, just a person off the street who randomly became a myofunctional therapist, or a dental provider, you're already messing up the field by comparing it to physical therapy. It is not physical therapy. But you know what else it isn't? It isn't speech therapy. There's a lot of people who want to say that, oh yes, it's just speech therapy, it is just a division off of speech therapy. Okay, boo, then it is a division off of dentistry, a division that you wouldn't have gotten had dentistry not invited you in. But I'm going to walk myself a couple of steps back, but it's not the same. It's why all speech pathologists don't do myofunctional therapy. It's something that they have to also pursue additional education for. It is easier to integrate. A lot of dental professionals lose their mind, lose their money, and waste a lot of time trying to invest in myofunctional therapy when they don't have the proper systems and workflows, and they don't understand how to really integrate it within a practice model so that they can be proficient at it, but also productive with it. And so that becomes a bigger issue. And so, yes, if we want to have that argument, I'll have it all day long, that speech therapists integrate this better into their practices and their processes than any dental professional. And that's because most of them haven't worked with somebody who knows how to do it. But I will say that speech therapy is not myofunctional therapy. There is a large component, yes, of the oral motor skills and the oral motor strength and awareness. And yes, being able to access and be more aware of your musculature, having it being stronger, is going to be able to help you build those skills so that when somebody comes in for some good oral motor placement, and they come in with a really good emphasis on articulation, and they really are diving into that, they can make better progress. Absolutely. I will stand 10 toes down on that. But I'm telling you, myofunctional therapy is not speech therapy. Okay. It is also not feeding therapy. There are some things we do where I could see you have a mild bit of overlap, but everything we do in myofunctional therapy, and I'll be the first person to tell you this is something I do full time to support my family of six. This is not as amazing and wonderful as you seem to think it is, to where we can rule out and eliminate a need for physical therapy, a need for speech therapy, a need for feeding therapy. Myofunctional therapy is basic AF. It's basic. You need collaboration, other providers, other modalities to make it stand out and to make progressive change that actually amplifies your outcomes and results and whatever. So if somebody ever looks you in your face and you're a dental hygienist listening to this and they say, I don't think you should be doing myofunctional therapy, well, hang on tight, baby, because I trust you know nobody is going to go harder for you than me. We write at dawn, okay? This whole lecture is dedicated to why I want no one to ever again ask me or anyone else why dental hygienists deserve to be in myofunctional therapy. And if you're thinking that, like, oh, well, I already know why, well, then sit down, because I bet you there's some things in here that you're not really articulating well enough or conceptualizing well enough to the point where you understand why we can be providers beyond screening. There's exceptional reasons why we should be ideal for screening, but we're not here to just help other people build their businesses. Dental practices should be building themselves up by knowing about oral dysfunction. And so if we're doing screening, it should be in-house, by the way, but it could also help to grow others in their practices if we just understand how we are a better network together, how we work together as a team. Okay. So I get that you think you know, but trust me, you don't know what you think you know. Okay. Okay. There's a beautiful infographic that the International Association of Airway Hygienists, and this is the work that I love to do. This is why I put my money, my time, and my effort. Like nobody stands 10 toes down behind hygienists like I do. I put my money where my mouth is. I put my time where my mouth is. The fact that you've got over 100, you've got nearly an hour, 100 hours of education here for free. Exceptional content that people will tell you you can't find anywhere else for free. The International Association of Airway Hygienists is the most affordable professional organization. We are trying to expand the limits of how we can protect and lift up hygienists. Nobody is going to go harder for you than me. Bet. But years ago, when it was even a first debate, 2023, this infographic was put out. And I feel it's high time that it comes back out again. We will revamp it. I will add the additional two things that I do have on this lecture to this infographic. But this infographic has been out for a couple of years now with the association, and the IAH is very firm in these five. We created them as a board. And so it wasn't just me conceptualizing these things, it was a board, a body of high quality, some of the best in the field, sitting down and coming up with this is why RDHs are so strong and why we deserve a position in myofunctional therapy, a position that we really shouldn't have to defend. But I promise you, you will get access to this even if you're not a member of the IAH. Now, I don't know why you wouldn't be one, because nobody's fighting for you like we are. Nobody's trying to educate you in the same vein as we are. And with legal plans coming up and all sorts of things, like I don't get it why you wouldn't be a member. But even if you're not a member, you'll find it in the Myo community on Facebook. And so hit me up after the lecture, and I will give you the link for sure. But let's dive in. We're going to explore these 5 reasons and 2 bonus exceptional ones. I'll tell you that there's probably 25 reasons, but we're going to go over the top 7 why RDHs in OMT just make sense. And before we get into that list of 7, I need you to understand entirely that we don't just scrape teeth, okay? There are a number of things we have to learn in school. Dental hygiene school is nothing short of trauma. People come out with sometimes a bachelor's, sometimes they come out with an associate's, and people seem to think that, like, oh, you just go to school for 2 years and you go to learn how to hold an instrument and get calculus off of teeth. Absolutely not. You have no idea the number of competencies we had to do. You have no idea the amount of minutia that goes into how you hold an instrument, and how many points you will get off if you don't have the right instrument, how many instruments there are, and how there is a method to the madness of that aspect of things. But we also learn radiographs. We learn how to shape amalgam. We learn how to place temporaries. There's so many expanded functions that we can do that you might not see your dental hygienist doing in the dental office every day, but we have to learn a whole bunch of things, because in every state, your abilities, like what you can do per your scope of practice, is different. And when that exists, you have to learn a gamut of things. So if you thought that all we did was scrape teeth, one, you were very wrong, exceptionally wrong. But just by educational standards, you were wrong, because we've learned so many things within dentistry that we can do that nobody ever talks about. And so let's just get into a little bit of the coda of it all, in how we have to be taught as far as education. Now, I think nobody understands entirely what it is we learn, but it's not just the 2 years of the dental school, because TikTok will get you all messed up in your head, think that all you have to do is go to dental hygiene school for 2 years and then you're good, boom, boom, bam, out. No, we have the same prerequisites to even get into a dental hygiene school that nurses have to get into a nursing program. So we're taking that same level of like anatomy and physiology and all of the background courses and so forth. But then on top of that, I'm sorry, but then on top of that, we have to take different types of psychology. We have to learn how to speak to people, communication, public and public. Oh my gosh, speaking, public speaking. There we go. It's the word I can't say that I'm trying to speak. That's funny. Public speaking, written. We have to be able to write. We have to be able to speak to people, understand their psychology. We have to take oral pathology, we have to take pharmacology, like all these things. You think that we just walk into a school and we learn how to count teeth and how to scrape them up? Like, no, we're highly educated, okay? So highly educated that there are many different responsibilities and things that vary between the states that we are capable of doing. Some of them independently, others of them in general supervision, which, if you don't understand general versus direct supervision, is not my job to teach you what you do not know. You need to seek out that information from reliable sources. But if you're going to question a dental hygienist by that bare minimum standard, understand what generalized supervision is versus direct supervision and indirect supervision. Okay. Okay. With that being said, our education far exceeds what I think most people understand that it is. I went to a university. I did not go to a community college. That does not downplay anybody who went to a community college. I'm just saying I got a high standard of education, as do my peers get a high standard of education, because we all have to meet these bare minimums. So it didn't even matter that I went to a university. I just spent more than others who were smarter and spent less. But we are educated. Okay. So if that was too hard to understand, then I'm sorry, because you need to either get with those bare bits of information that's going to get us together, or you could get lost, because we're here and we belong here and we deserve to be here, and we're going to stand proudly in this space, because that's what hygienists do. We stand proudly in everything we do. Okay. So number seven, the list is in no particular order. It's literally just the top seven, okay, reasons why we belong in this space. And I would love any sort of input anybody else has. So throw them in the chat as I see them. I will grab them. But here we go. Dental hygienists have immense tactile awareness. We have our hands in the mouth all day, every day, in everybody's mouth. We have our hands in our own mouths. I don't know a hygienist that doesn't have scalers. I don't practice hygiene clinically, and I have scalers, and I will like clean my own teeth every now and then. Like, we are tactile aware. We place our fingers to palpate, to retract, to to assess and like manually really figure out what's going on with oral mucosa, soft tissues of the lips, the cheeks, the throat, the neck. I'm sorry, because we're not putting our fingers down anybody's throat, but the neck, we will go in and feel. And we get the small nuances that exist between tissue. When I've felt hundreds, maybe thousands of mouths, I guess, in my career, you get the nuance that exists when there is a muscle that is overdeveloped, when there is a muscle that's underdeveloped, that doesn't feel quite right. You have a unique perspective on oral muscular dysfunction versus other people that never get intraoral ever, ever, at least not clinically. And if they do, it might be too prompt, but it is not to generally feel and get in there all the time. So even if, let's say, you're a not your subpar dental hygienist and you don't do an intraoral exam or an extraoral exam, and you're not feeling the patients as you should, let's say you're subpar, okay, you're still getting your hands in their mouths to retract and to feel a lot of different things. Sometimes we'll see differences in the mucosa. Let's say there's been times where I've been subpar and had to work in an environment where it was really pushing me on time, where I would have to see like 16 people in the first 4 hours of my day because I was working in a corporate environment. But I would still be able to say, hey, there's something odd in the cheek there. I put my fingers on it and palpated it. It felt a little bit cratered in the center, and I think you might want to take a look at that, doc. I would still be able to assess that there were changes in the oral mucosa. We have that tactile awareness, and we are taught with a very keen eye to be able to describe it, to measure it, to understand what is within normal limits and how to define outside of normal limits. So when there's changes, guess who's going to be the first to know? Your dental hygienist. Like, as a myofunctional therapist, you're the first to know because you get your hands on there. You understand the difference. You're looking at the difference and you have that visual acuity, but that tactile awareness. What? Are you serious? We're in there. We're in there. We feel it. We know. We understand. While everybody else wants to use or get or really like break down with like an IOPI or some type of measurer. They need a lit meter. They need something else to understand whether there's change in the musculature. I understand for data, you want some of that. But really, if you keep it to bare bones simple, there's nobody who's going to be able to tactile wise tell you that there is something changing in muscle than a dental hygienist, because we are going to get our hands on it. We will feel it and we will understand it. So, your best evaluations, your best myofunctional therapy evaluations, I bet my life on it, come from an RDH because we know oral tissue, hands down. Okay. Keeping it absolutely simple. Nobody's got better hands than us. Intraoral. We're the bomb.com. Okay. Number 6, visual acuity. We are in there with loops. Many times there were years where I practiced without loops because I didn't love my loops. My loops were not the best. When I first started out, I did buy some in school, but it just wasn't the best. So visual acuity is going to for sure be spot on when you're not using loops. And you have to get and see. When I tell you the trauma of dental hygiene school, and you have to get in there and you have to really see the calculus and you have to really see what it is you're trying to clean off, and you are reflecting light from that hand mirror. You're looking in the mirror and you're reflecting light and you're drawing the tissue. You're going to see, I swear I'm going to see it, guys. Or I'm bending in so that I am like literally right on top of this person's mouth so that I can see our visual acuity for like the smallest of things. It's top par. Okay. Oral dysfunction is first visibly is first seen in occlusion more often than not. Sometimes seen in the oral mucosa, and so you'll see changes in the color or the texture of the oral mucosa, but it is first seen a lot of times in the occlusion or these areas where other providers aren't looking. You're not looking for the nuances of a class 2 div 1 versus div 2, whether or not it's an overjet versus an overbite, whether or not it's, a unilateral posterior or like generalized open bite. Like, you're not looking at these things that we name all day every day. We're doing it. Before we become myofunctional therapists, we're in occlusion. Like, we had to know occlusion in school. My very first competency, fun story about trauma, because that's all we have when you come out of dental hygiene school. There was a dentist who was a professor at the university where I went, for the hygiene school. And she came over to me and I got something wrong on occlusion, on my partner, who is still my good friend to this day. I love her so much. But I got something wrong on her occlusion. And she looked at me, this dentist, and she said, "You're not cut out to do this. You are not cut out to be a dental hygienist if you don't know occlusion." Understood. That was my motivation to do better. And I did better. I did better. I do occlusion all the time. Look at me now. I'm a myofunctional therapist. So haha to her. Okay. I was more than cut out to do that. But we have the visual acuity to note these small changes. We're the only people who really should be looking at occlusion when we're talking about any sort of myofunctional therapy. There's a lot of people out here recommending appliances and talking about appliances and doing all sorts of things with appliances. But like, boo boo, you don't know not none of that, not nan of that, like a dental hygienist does. We are the top notch for that type of stuff. Number 5, orthodontic knowledge, which goes hand in hand with number 6, that visual acuity and how we know and we understand. We are working a lot of times, if you are in any sort of corporate environment, or if you're in a group practice where there is an orthodontist, or if a lot of these practices are doing clear aligners and they have changes in ortho that they're noting so that they can then subsequently, recommend treatment and so forth. But the impact of ortho and malocclusion on periodontal disease, we know perio is our whole life as a hygienist. We're always in there trying to know that. But our orthodontic knowledge and being able to see the shifts and the impacts of the soft tissue on the dentition, and is there changes, because we're following you for a long time. Many of you have had a hygienist, the same hygienist, for forever. We know your mouths. We see the changes. We understand what's been making these moves and these shifts. And guess what? As myofunctional therapists now, we're amplifying that knowledge to then work in collaboration better with orthodontists than any other professional. Than any other professional. There's so many orthodontists who are like, it really took a hygienist to get me into myofunctional therapy, because I didn't believe in any of that. And many of my colleagues and my peers still don't. But it took a hygienist to really sit down and explain it with me. You right. We're out here championing for the rest of the field and these other professionals who are not as aware as we are of those connections between the orthodontics and that soft tissue, constant light pressure, and how it makes an impact and how we can make the biggest impact. One of the biggest things you can do is to help if you want to get bimaxillary protrusion. The biggest thing you can do is, if your patient has a deep bite, start some myo. And my hygienists understand why. That way, the next step, because they cannot advance anything until that deep bite has been resolved, or at least is starting to getting worked out. So if you have soft tissue dysfunction that is perpetuating your deep bite, like, what are you doing? Why are you sending them to the orthodontist if you don't even understand how the whole orthodontic system works, and you don't get occlusion the way we do? What are you doing? Confusing yourself and confusing your patients, and then leading them right into the arms of a hygienist where they'll be like, you get it. Yes, we do get it. We understand. Number 4, are these like really colorful, fun graphics? I love it. It's so cute. Okay. Dental hygienists are seeing people younger and younger and younger. As a former pediatric dental hygienist, I have so much compassion, heart, and just love for my pediatric hygienist. Pedo was my favorite time in hygiene. I love adults, but I really loved working with the kids. And we would see babies. We get to be in there from like when they're really, really small, and they get these cute little one tooth, and then we take our little toothbrush and we brush their teeth and we talk to the parents, and we're really getting an early foundation in what's happening. We start talking to them about the sippy cups. We start talking to them about the thumb sucking and the pacifiers, and we've been doing that for generations of people. Dental hygienists should be always in a conversation about myofunctional therapy, because last I checked, I don't know, I could be wrong, but some professionals are not seeing some of these babies that are healthy babies, at 6, 7, 8, 9, 10 months old. I don't like if they're healthy. Are you seeing them? Are they coming in with a problem? Would you know that they're on their way to a problem? If not for a dental hygienist who was able to sit there and really make the relationships. And it's like, tell me you don't understand dentistry without telling me you don't understand dentistry if you think that the dentist is the main person having those conversations. Now, will the dentist come in and have a light conversation? Absolutely. But the dentist has 8,000 things to do in a 1 hour time period. They come in to do the quick 1, 2, but we get our 30 minutes with a child. We get our hour, hopefully, with an adult, to really do a good bit of education. And so, because we're there and because we know and we understand, and one of the things we learned is oral embryology, and so we're able to see some of the things that are coming along, and we're able to see as teeth are starting to erupt, and we understand the developmental timelines and windows, and we're able to really tell a story and paint a picture of that early trajectory significantly better than any other practitioner. And if you've already had that experience, why aren't you a myofunctional therapist? You are, if nothing other than at that point, a functional health provider. Like, you are really helping to change the trajectory of their health in a positive manner. Early identification, I think, is one of our biggest strongholds, and I'll always stand 10 toes down on that being why we need to be more so in myofunctional therapy than anybody else. Yes, you can count that for screening, but also because we have those conversations in office as clinical myofunctional therapists. I talk to a lot of people who book time on my calendar. My consultations are absolutely free. I don't charge not a dime to speak to me, to block 30 minutes of my time. You get to speak to me and I will absolutely talk to you about whatever. And so I get people with 1 week olds, I get people with all sorts of babies. So I get to talk to them about what's going on, what are they struggling with? Do you really need to go straight to a release provider, or should we be going down that functional path? Should you go see my friend, the feeding specialist? Should you go see my friend, the occupational therapist? Because there might be like something else going on, some physical therapy you might need, whether it be torticollis or plagiocephaly. Like, there might be other things going on that are kind of mimicking what's going wrong. And so you want to make sure that you're crossing all of those. And so, yes, we should be in the field of myofunctional therapy, even just conversationally, because we are a lot of times traffic directors. We're go here, stop, go there. Like, that's what we do. Okay. Number three, frequent touch points, because hello, we're the most visited and we spend the most time out of all healthcare providers. We're spending a lot of time with healthy individuals. People are coming to us, if at nothing else, twice a year to get something that they feel like is deserved. It is deserved. It is deserved, but it's so much more that they're getting. They feel like they're just coming because I deserve my cleaning, but they get so much more. They get a full health experience with a provider who is a functional health provider, who is, the mouth is where digestion starts. The mouth is honestly the start of a lot of health deterioration, or where you start to thrive and fix your health, because all those things you start putting into your mouth. We counsel on nutrition. Like, we do a lot of things that nobody thinks that we do, and we do it with healthy people who don't know that they have a problem. And I'm actually leading into my next point technically, but what I'm saying is we're seeing people that you would never see unless they were referred to you. And why would they get referred to you? Because they have some problem that somebody else found, or because somebody told them that they need to go see you because of yada, yada, yada. And so I think it's really important It's incredibly and exceptionally important that we start recognizing that hygienists, if you're doing dual duty, you're seeing a lot of people that you would then see again and again, and you get to make those touch points that as a myofunctional therapist, you're seeing their progress over time and you're able to monitor it from both ends. You're seeing the quality of their oral health, you're updating their medical history for their dental records, you're able to see what's going on a dual lens. Their oral health is, yay, it's on an upward trajectory. Their systemic health is on an upward trajectory. They're not fogging up your mirror. They understand how to nasal breathe. Personal trajectory for your professional sanity. Yes, it's all going up. And so I think it absolutely warrants that we be in this field because we're able to really get the rapport required to make these changes. Okay. Number two, yay. We are champions of behavioral change. We are not behavioral therapists, but we are natural coaches and natural educators. We're always encouraging behavioral change, be that nutritional, behavioral, for sure. Anytime you're told about flossing, or we're sitting with you and we're demonstrating, or we're using a prop and we're really getting in there, like we do coaching and education. And what is myofunctional therapy if not repetitious coaching and education? Anybody have any idea what it could be beyond that? Because physical therapy ain't it. It's not physical therapy. If anything, it's more like personal training. And I really need more people to understand that, to conceptualize that, because the more you're driving for some force of change, you're like, oh no, we need this to be something where it is a part of our licensure. You're going to have states that lag behind. Think of how long it took. I don't even think we have all states that have local anesthesia for dental hygiene. I'll have to go back and check the ADHA charts that they have that I showed the little video of to see. But I think there's still one or two states where they can't do local anesthesia. And local anesthesia has been around since what, the 80s, that some hygienists have been able to do it. We don't have license reciprocity. God forbid you move. Now you can't do myofunctional therapy somewhere else. Like, that is just wild. It's just wild. It's not that serious. It's really not that serious. Like, get that around your heads. Like, myofunctional therapy does not have the scientific backing, the evidence-based backing to be in anybody's licensure, by the way, because it's not dental hygiene and it is not speech therapy. It's not physical therapy. It is not any of these things. It's more like personal training for all of the muscles that nobody thinks about. And we don't have any licensed personal trainers in any state in the US. I don't know that there's a licensed personal trainer anywhere in the world globally. So do we really need that? I don't know. But like, what are we not getting back on track? You know, I get off my tangents. I'm sorry. I love you all. Um, what is it if not just a continuous prompt for them to make a behavioral change? We're doing that multiple times a day, every single day with people. And people think that that's not what we do, that we just go in there and we clean teeth or we tell people to floss more. No, no. We are educating them on a lot of things. That pharmacology education doesn't go for naught. We are looking at some of your drugs that you're taking. If you're taking a beta blocker, like, this is what it does to your oral mucosa. This is why you might see some sloughing of a soft tissue, because you are on this medication. Like, this is what we're going to have to work with and how we're going to be able to manage this. And so I'm going to need you to make sure that when you're doing your daily hygiene routine, like, everybody's not the same. You're not getting the same oral hygiene plan. We don't do just broad spectrum oral hygiene coaching. So we wouldn't do just broad spectrum myofunctional therapy. Like, that's just not how that works. Okay. So We are champions of behavioral change. We should be in myofunctional therapy. And frankly, frankly, I've never met more type A individuals than anybody in dentistry, honestly, the dentist and the hygienist. We are all about protocols and sequencing. There's nothing we love more than like following a good protocol. Yes, that's our protocol. We have some complicated like periodontal staging and grading, and you got to do this and understand that. And then we're looking at all these different measurements and we're doing whatever. We love a good protocol and a good sequence. And with that being said, that's myofunctional therapy. If you can follow a protocol and or a sequence, you can be a myofunctional therapist. Whether you be a physical therapist, a speech language pathologist, an occupational therapist, or yes, a dental hygienist. If you can follow a protocol, boom, you've got like 2/3 of the way there. You're pretty much a myofunctional therapist. You just haven't learned yet the protocols or the sequences. It's really important that we start to like take that part of it more seriously. That we are type A individuals who can follow a sequence and protocol. We do it all the time for much more advanced things. We screen for oral cancer and we follow protocols for that. We screen for perio, we follow protocols for that. We do nutritional behavioral counseling. Like, we are just freaking awesome. We are awesome beyond awesome beyond awesome. Okay. And if you didn't know before today, hopefully you do know, and that is the real big takeaway that you've got here. Okay. So, with that being said, I'm going to remind you all of who you are, what you are, and how powerful you are. Take up space because you belong here, okay? You belong in this space as registered dental hygienist. Don't let nobody tell you that you should not be a myofunctional therapist. And the next person who puts time on my calendar to come and try to tell me that or try to talk to me about that, we're not going to have a good time on that call. It's not, don't do that. So, with that being said, I appreciate you all. Thank you for joining me for this amazing live. Another one is going to pop up on your screen. So, watch the next video to keep your roadway to excellence paved. Love you.